When the ACTG was first established, AZT was the only drug that had come out, and it was only good for people who were literally dying of AIDS. And it was shown that it helped those people live longer, only 6 or 8 months longer, but longer. And so the next question was, is AZT good for everybody with HIV? And so that was the first study in the United States that tested thousands of people and gave them AZT and found that, in fact, yeah, it did help them. It slowed down the HIV. It didn't cure anybody. It didn't save their lives like subsequent therapies have, but it really did work. And we were part of that very first study of AZT.
I recall the work we did regarding the new drug in 1990, fluconazole. We used that little pink pill and studied thrush, where people got plaques on the inside of their mouth. We also used it to study candidal esophagitis, whereby people could not swallow, they could not eat, they could not drink. And the only alternative was a severe toxic drug called amphotericin B, and it was a lifesaver.
So one of the first things that decreased the mortality in HIV patients was the release of azithromycin and clarithromycin. Even before HIV treatments were available, the mortality curve for HIV infection started to go down. So even before we could treat the virus effectively, we had newer medicines that prolonged people's lives. And these were some of the trials that we participated in the late 80s and early 90s, I think, that helped people a lot.
The first patients that were identified with, now we know it as AIDS, were identified with Kaposi sarcoma, the cancer that was associated with the disease, and pneumocystis carinii pneumonia. The patients became unable to breathe, short-winded, and when we admitted them to the hospital, we learned when we looked at their sputum that it was teeming with pneumocystis. What worked? Trimethoprim sulfa or Bactrim. That was a very old drug that actually killed the bug. So probably one of the biggest accomplishments over the last 15 years was that not only staying on Bactrim prevented pneumocystis, but when you were on highly active antiretroviral therapy and taking it every day, we were able to stop Bactrim therapy. So that was one less pill to take if your virus was under control and your immune system was improved with an elevated CD4 count.
But we still had some other infections that were really big problems, and one of those was disseminated MAC infection. And we found over the years through clinical trials that just giving simply 2 pills of azithromycin once a week could prevent this complication. And again, even before we had effective HIV treatments, preventing infections like MAC would prolong people's lives.
Earlier in the era of HIV care, patients came to my office and they would be complaining, Doc, why is my belly so big? That was a real noticeable complaint that sort of came out of nowhere, right as we were getting more effective therapy and protease inhibitors and things that were working well for our patients. Other body changes they would notice would be maybe thinning in their arms or legs or in their face, and they would wonder, are my medicines doing this to me? And at first I wasn't sure, but sure enough, we saw this on repeated occasions with patients, and then in conversations and collaborations with other centers around the country that we are part of with the AIDS Clinical Trials Group, we realized that this was indeed happening to our patients, and it was something that was going to be important to study. So, at the same time that we were trying to figure out what was causing these body fat changes in patients and what maybe we could do to have an impact on that so it would not happen or so we could correct it, we were also studying new agents as they came on the market, agents that had advantages in other ways. And one of the things we were able to recognize through our studies is that there were certain options for treatment that had much fewer side effects, that were much better tolerated, but also were much less likely to cause the body fat changes, the cholesterol elevations, and the other negative side effects that we had seen earlier on. So this was a major advance for our patients.
For those of you who are old enough to remember, the early days were tough. There weren't any medicines, and the medicines that were initially developed were hard to take, had lots of side effects, and quite honestly didn't work that well. But then in the mid-90s, 1996 I believe, when the protease inhibitors came about and the idea of combination therapy came about, that was an altering moment in the event.
And we knew that already you had to use these drugs in combination. We had learned that. The ACTG had taught us that we had to use drugs in combination. So we added that rather than just gave it by itself. And once we added that, it was a triple drug combination, and really that was the first time we had ever seen the virus just completely be stopped.
And I think when you think about once-a-day regimens, it's been a huge impact on people's lives. They've been able to go back to work. They've been able to take their medicines regularly without having to deal with multiple pills. They've been able to actually function in a normal lifestyle. I think that's important for us because we were actually part of that.
What we also know that with HIV treatments, that we can actually repair people's immune systems almost back to normal as long as they take their medicines and keep their virus under control. And we've done studies through the ACTG or the AIDS clinical trials groups that have shown that some of the newer vaccines like the shingles vaccine or the chickenpox vaccine are probably safe to give to HIV patients and could help them out a fair amount in the future.
Well, one of the things that we do here that I think makes this place really special is our participation in the MACS, the Multicenter AIDS Cohort Study. Now that's a very important study that's been going on since 1983, really since the start of the epidemic. And it's been the source of a lot of information that has really helped people who are living with HIV live better and longer lives. And we're one of only 4 other places in the United States participating in this study.
So I think the other important thing about Ohio State is that not only do we take care of patients and are involved in the research, but we also continue to educate ourselves as well as others. We go to national conferences and international conferences and present information to our colleagues, but we also listen and absorb and learn what's happening and what are the issues, not just here, but elsewhere, and how we can use all that information to make it better for us and the patients in our community.
I'm happy to be working in an environment where not only myself being encouraged to stay up to date on things, but also being around colleagues who I can turn to. And when I have patients who maybe challenge me with their problems, I have bright people all around me. And if it's not something that I'm involved with directly with research, my colleague down the hall is, and they can keep me informed about what other options my patients might have.
I mean, that is really what we do. We educate each other, and we do this with students and residents and all sorts of trainees. When we don't know the answer, we ask one of our colleagues who might know the answer, and if they don't know the answer, we know where to go looking and who to call about problems.
One good thing about coming to OSU is that we have both a research staff and a separate clinic, but we're together in the same area, and so we work closely with each other. So we have the research nurses and the research pharmacists, and we work together with the clinic staff in coordinating care.
We have a great staff. Our staff is a team, and being part of that team, I'm very privileged, and I think it's honor. It's a great place to work. I see so many patients come through with the diagnosis, of the HIV or AIDS, and they're frustrated. And when they come here, we want to make sure that they feel special, or they feel like they can come to a place and not be judged. Being part of OSU to me is wonderful because we offer them the OSU My Chart through our system. We work with our pharmacists to have a patient assistance program that we can help them get their medications, because that medication is extremely expensive and not every patient can afford it or has insurance.
I've been a nurse for a really long time, and I've worked with all kinds of doctors. And I would say by far this is the best group of doctors that I've ever worked with. They take the time to listen to you. They want to know what's bothering you, what's important to you as a patient, because they know that affects your overall health too. So, I mean, I just think they're great. And I feel like I can still say that after 21 years of working with them. So we've got great doctors here.
When HIV first came out, I mean, there were no treatments. Everything was an experiment. Every drug was being tested on people. And so we are in that mindset of, and that's what the university does. It seeks new knowledge. It seeks better ways for doing things. And so we're not satisfied with what we have. We're always looking for better.
So I think we've done a lot of work to really further the care of HIV patients and to help prevent things that really in the past we were wondering whether we could or not.
Hepatitis C is now one of the major killers of our co-infected patients. If you need treatment for hepatitis C, come to our clinic. We have studies to treat hepatitis C, which will help you live longer.
The world of HIV clinical research has been one of the great success stories, quite honestly, in the world of medicine. And it's thanks to people who participate in research that we have learned so much. And the reason we do research is because people come to us with questions that need to be answered.
Well, in my practice, the vast majority of the patients that I see each clinic session have HIV. And I think they look to me for advice. Even if they're doing well on their therapy, I always have my patients are asking, what's new, doc? Is there anything out there that I should be aware of that perhaps I should change my regimen?
This is something that's going to be with them for the rest of their life. They really need to understand it. They need to understand it from the very beginning so they can make some smart decisions early on. They need to get on the right medicines. If medicines are appropriate for them, they need to have a discussion with somebody who's an expert, who has experience in this, about when to start meds and what might be appropriate meds. And so I really do think the most important thing a person with HIV can do is talk to somebody who really knows what's going on.
At the risk of sounding full of ourselves, HIV actually is our business. We do this every day. We keep up with things on a day-to-day basis, and we provide that expertise to our patients.
And we know, we have done this for a long enough time. We know the conversations. We can talk about things that they hadn't even thought about yet, and help them through this time of crisis sometimes.
I saw a patient on the consult service the other day who we were just chatting because she's actually a psych nurse, and we were talking. We were talking about transplant infections and stuff like that. And I said that was sort of my original. That's what I originally came here to do. But then there was HIV, and she went, "Oh, those poor people." And I said, "Well, they're not really poor people anymore. They can be healthy people as long as they get care."
And our doctors and the clinic staff, they work so closely together, and they're a well-grouped team, and I just feel that we care very much about our patients, and they're not going to find that anywhere else.